Hello, everyone. Welcome into our free webinar today. I am so excited you're here. Just doing a quick sound check, video check before we, go down the rabbit hole. Want to make sure everybody can see and hear me okay. Give me a thumbs up, heart, comment, whatever works for you. Let me know if you are able to hear and see this okay. Beautiful. That's great. Welcome in. Hi, Anna. Hi, Sarah. Shelby. Welcome. Welcome. We're so glad you guys are joining. This is part of our nursing school series. And today I am going to be teaching you high level, what are the big pediatric respiratory disorders you need to know? For those of you who don't know me, I am Dr. Morgan Taylor. I am a pediatric nurse practitioner, so this is my bread and butter. I really love peds, and I love that I get to share some really common pediatric conditions with you. We have lots of respiratory stuff that goes on in our kiddos. So this is important if you're in your pediatric class in nursing school, if you're studying for your boards. Really, this is going to come up. For those of you who are maybe not familiar with Archer or what we have, I'll just quickly show you what it is so you know before we jump in. So Archer Review, we are your guide throughout all of nursing school. That means we have a comprehensive course that goes along with any course you are taking in nursing school. So like today, we're doing pediatrics. We've got a pediatric course for you. What is in that course? We have practice questions, we have videos, and we have cheat sheets and notes. So whether you're an audio learner, a visual learner, whether you really want to practice those questions, we've got a whole suite of resources so that as you go along in all of those courses, we can put Archer Review in your pocket and you can have a backup, a mentor, a guide to really get you through it. So my goal today is to give you a little taste of what we've got. I'm going to give you an excerpt from our pediatric respiratory lecture. And we're really going to hone in on those most important concepts, those 5 big disorders that if you work in kids, or if you have kids, or if you're around kids at all, whatever, you're definitely going to see these. So everybody ready to get started? What do we think? Give me a thumbs up. Let me know in the chat you guys are ready to go. Amazing. Okay. Sounds like a plan then. Let's jump right to it. And what we're going to do is start off with a bit of an overview here of how the pediatric respiratory anatomy works. Okay. It is commonly said that kids are not just little adults. And that could not be more true when we talk about their airways. There are some really key differences in how their little airways are shaped and structured that makes caring for them different. So the first one is that they're smaller, okay? So proportionally, the infant's airway is smaller compared to their body than an adult. And naturally, when you've got something smaller, it's easier for it to get obstructed. Think about if I had like a giant fire hose versus a little teeny tiny coffee straw. It's not going to take very much to clog up that coffee straw if that's the infant's airway. Versus I've got a lot of diameter here for my fire hydrant hose. That's going to take a lot more to obstruct it. So that's the first reason kids can have airway problems super fast. Secondly, their reserve is just less, okay? So their alveolar surface area, how much room those alveoli have to exchange oxygen and carbon dioxide, they just don't have as much of it. So when they get a respiratory disorder, progresses more quickly and they've just got less backup. So they can get pretty sick pretty fast. Their bodies also need more oxygen. They have high metabolisms, they're breathing fast. They just use a lot of oxygen. I always think of it as, kids are growing. Obviously, they're getting taller, bigger, developing, growing their brains, their organs. That requires fuel. The fuel for your cells is oxygen, yeah? So they're using up a lot more of it, which means If they get some sort of respiratory condition and they're not able to get as much, they're going to get sicker faster than an adult would. And lastly, the way that they breathe, so we know they're using a lot of oxygen, they're breathing faster, but the way they breathe, the muscles that they use to breathe are not as developed. So we know we've got the diaphragm, that's our major muscle of respiration. We've also got those muscles in between the ribs, the intercostal muscles, and those actually move our rib cage, move our lungs, so we inhale, exhale. If those muscles aren't as developed, they're going to get way tired, way fast, and they're just not going to be able to keep up, okay? So that's why one of our key indicators of respiratory distress, especially in pediatrics, it's how hard are they breathing? What's their work of breathing? And we see when they're using those extra muscles, like intracluster muscles, subclavicular, all those, when they have retractions there because they're using those muscles, we know that's a sign really quick that they're not doing so hot in the respiratory department. So that's a broad overview. Those tell you kind of the big reasons why kids are different from adults, how things are shaped differently. And we'll kind of touch on these as we look at each disorder and how we're going to treat it. Now, the 5 key things I'm going to walk you through today. We're going to start off with some acute disorders. We're going to do bronchiolitis, croup, and epiglottitis. And then we'll look at our 2 most common chronic disorders, asthma and CF. That stands for cystic fibrosis. Yes, there are other respiratory disorders in the world. There's pneumonia, there's ARDS, etc. We hit those in adult med surg. Adults can have these conditions too, but these are the really common peds ones. And that's what I want to hit home on today. So what we're going to do here, we are going to start in the lower area of the respiratory system and work our way up through these acute disorders. So the lowest one we've got here, it's called bronchiolitis. Have you guys heard of this before? Go ahead and put in the chat, yay or nay. Have you heard of bronchiolitis? Is this new to you, or is this old information? I bet if any of you have kids, you're like, yeah, I've definitely heard of bronchiolitis before. My kids get bronchiolitis all the time. This is really common. Daycare, it definitely goes around the daycares a lot. Okay, I'm getting mostly thumbs up, it looks like here. So I think a lot of you at least know somewhat what bronchiolitis is. You know, itis means inflammation, and you know the bronchioles, little branches off the bronchi going down in the airways, right? So bronchiolitis is when those bronchioles get inflamed. That is all bronchiolitis means, inflammation of the bronchioles. But what actually causes those bronchioles to get inflamed? It can be a number of things. Usually it's a virus, and usually the virus is respiratory synaptical virus, or RSV. Now, if you haven't heard of bronchiolitis, I bet you've heard of RSV before. So sometimes people call it RSV bronchiolitis. But I think it's important to know they are distinct. RSV is the virus, the actual little pathogen that gets on in there. And the bronchiolitis is the inflammation of those airways. This is a seasonal illness because, you know, just like all of our other viral illnesses, it has that peak over the winter yucky season, okay? October to November and December to February is kind of when we see it. Starts declining by April. When it gets warm, we're outside, more spread out. Now, what are we going to see when our child gets bronchiolitis? They're going to have all the yucky respiratory symptoms. They're flaring, they're retracting, you know, they're just having trouble breathing. They've got lots of snot, boogers. They're not feeding as well. They're not really wanting to eat. Not wanting to eat is a-okay in a sick kiddo. When I get worried is when they're not wanting to drink anymore. So we're always asking about those ins and outs. Are they still having wet diapers? Those are all the things you want to be aware of, especially in our high-risk population. These are going to be premature infants or infants that have other sorts of lung or heart disorders. So like a congenital heart defect, like perhaps a PDA or an ASD, or another chronic lung disease, like we'll talk about cystic fibrosis later. Those kids will get much sicker much faster. And because of that, they are eligible for a vaccine. This vaccine is called palivizumab. Synergis is the brand name here. And we give it to high-risk infants during that RSV season to try and prevent them from getting sick, having all of that respiratory distress that naturally comes with our bronchioles being inflamed. Okay, now I want to hone in on the number one key symptom of bronchiolitis, because a lot of this is very non-specific. You're like coughing, nasal flaring, retracting. Like we can see this with any respiratory disease. What really makes me as a provider think this could be bronchiolitis is when I start to hear wheezing. Remember, that's that high-pitched, it's almost like a whistle situation, that sound that you hear. And it's happening because those bronchioles are getting smaller. When they're smaller and air is trying to flow through them, it has a more narrow diameter and it makes that whistling, that wheezing noise. So if a kid comes in and they're, a little bit of work of breathing, some green snot, whatever, but their lungs are perfectly clear, usually think bronchiolitis. When I hear that wheezing, then I really start to think, okay, we could have some inflammation down there. Unfortunately, at that point, there's not a ton that I can do to help. I don't have like a magic antibiotic. Why don't we give an antibiotic? This is not bacterial. It's caused by a virus. RSV is the virus. No antibiotic in the world is going to help them, right? I don't have some magic medication that gets rid of RSV. So we really focus in on supportive care and stopping the spread. Supportive care means everything to help them breathe easier. Clear their airway. Airway clearance with lots and lots of suction is key in infants because they can't just blow their own nose. So we have to do that for them. If they have decreased oxygen saturation, then yes, we'll give them some oxygen. And we really work to keep them hydrated. They're breathing faster. They're having lots of insensible losses, so they can get dehydrated really quickly. That's why we keep an eye on wet diapers. We want them to have at least 4 to 6 wet diapers per day. Otherwise, we know they're dehydrated. At that point, we would try to escalate their care. We would say, all right, you're not getting better. Our supportive care is not working. We need to go ahead, go to the hospital for IV fluids. Maybe they need some high flow nasal cannula. Any of these signs down here of respiratory distress, turning blue, excessive tachypnea, are signs they're getting worse and they need more care. In the hospital, preventing that spread means droplet and contact isolation. So that means gown, mask, gloves. We're going to sanitize when we're going in and out, all that good stuff. Okay, so key takeaways, little exam tips for bronchiolitis. Remember, we started down low, inflammation of the bronchioles. Priority is to clear their airway. Make sure that you stop the spread by initiating those contact and droplet precautions, and be aware of signs and symptoms that indicate the need to escalate care. Okay, everybody feel like they've got bronchiolitis? What do we think? Ready to move up in the airway a little bit? I think you are, but let's do a practice question. I just want to check in with what you guys think. We've got a 2-year-old with RSV bronchiolitis. They've been admitted, so we had to escalate their care a little bit. Look at these interventions and go ahead and comment in the chat, in the box, in Instagram, wherever you're listening. Comment with the letter of the correct answer. Which intervention is the priority? We've got administer albuterol, start IV antibiotics, suction their secretions as needed, or place them in isolation. What do you think? Okay, I've got C looks to be an answer we got over here. C, okay. Let me know what you think. Yeah, okay. Lots of people B. All right. I'll give you another minute or so. I got D coming in here. May says C. Shauna says C as well. So does Sandra. Okay, yep. C, okay. And I like here, we got a comment on Instagram that says C airway first. And I love that rationale. Good prioritization. That is exactly why C is the correct answer. Now, there were two answer choices here that were appropriate. Suctioning and isolation are both things that we do. But in prioritization questions, we always follow those A, B, C's. Airway comes first, and suctioning out that airway is huge. Now, B, absolutely incorrect. Why is B incorrect? Everybody go ahead and tell me. Why do we not start IV antibiotics? I don't care how sick from RSV bronchiolitis. Why are IV antibiotics not going to do it? Because Michelle's got it. RSV, respiratory synaptical virus. It is viral. Antibiotics are for bacteria. So really, as much good as you want to do, you're not going to help them with B, start IV antibiotics, okay? And albuterol, not indicated for bronchiolitis, okay? I have seen some providers, if we're worried about some underlying asthma, sometimes they throw albuterol at it. But let me tell you, it's not evidence-based. It is not going to be the right answer on a test, okay? So let's move up the airway a little bit and talk about one of my favorites. It is called, we're going to go with the fancy name first here, laryngotracheobronchitis. I am sure you have heard this called Croup, much easier to say. But the long name does actually tell you exactly what's going on. Laryngeo, your larynx. Tracheo, your trachea. And bronch, your bronchial itis. Inflammation, of course. All right. So LTB, laryngotracheobronchitis, we have got inflammation all up in that upper airway, larynx, trachea, and the bronchi. Now, this is another one triggered by a viral infection, okay? Most of the time, it's parainfluenza caused by a number of viruses. To be honest, a lot of times we don't even check to see which one it is because it doesn't really matter. We just know they got a virus and it triggered edema in that upper airway. So it got really swollen, really inflamed, and that's what causes the very classic symptomology. They have a barking cough, inspiratory stridor, and hoarseness. Okay, now what are you super worried about as soon as you heard me say inspiratory stridor? That stridor, that high-pitched as they breathe in. We're worried about their airway, right? Stridor is an airway emergency finding because it means their airway is closing. So there's two different peds respiratory things that can cause stridor. Croup is one of them. The big giveaway, though, is that barking cough. And it's typically much, much worse at night. So much so that I'll have parents come into clinic in the morning. The child literally looks perfectly fine. And they're like, I swear they were up all night. They sounded like a seal. They were barking so much. And as soon as they say that, like barking or sounded like a seal, I'm like, oh, they have croup. I don't necessarily even need to hear it because seriously, they're so much better during the day. At night is when it gets really bad. If it's very mild, we can just do some non-pharmacological interventions like going out into the cool night air, running a humidifier. A nice trick I like to pass on is like sitting next to the shower, turn the shower on really hot, let it get super steamy in the bathroom. And that kind of humidity that can cool down some of that inflammation. It gets worse though, and I typically do like to treat with a little bit of a steroid. Steroids reduce inflammation. We've got inflammation in the upper airway. let's get rid of it, right? So the steroid we use is dexamethasone. It's given in a very specific dose, 0.6 mg per kg, and we give it one time. So kids can come into my office. I give them this one dose of steroid. I usually literally do it in the office. They go home and they are so much better. What do we not need to give? Antibiotics. It's not a bacteria. Once again, we have a virus causing inflammation. So I'm just trying to decrease that inflammation. Now, if a kiddo comes in and they have inspiratory stridor at rest, they're sitting there resting and they're going, they literally can't breathe. They're turning blue. Their oxygen's going down. They have lethargy. They're out of it. That is an emergency. We need to go to the ED, and then we will do an additional medication called racemic epinephrine. Okay, what does epi do? You guys tell me down in your chats. Epinephrine is a what? What type of medication is this? We don't usually talk about it in like the respiratory world, but I know you guys are familiar with it. What does epinephrine do? Okay, yeah. Blood pressure. I'm seeing people say it gets the blood pressure up. We give it in shock. We give it for allergic reactions. Absolutely. So at its core, like pharmacology, epinephrine vasoconstricts. It makes the blood vessels smaller. That's what gets the blood pressure up. That's what helps in those allergic reactions. So if we give it right into the airway, if we nebulize it and give it in the airway, it's going to vasoconstrict all those little vessels in the upper airway, which really quickly decreases edema, opens up that airway, decreases stridor, makes it so they can breathe easier. This is only an emergency med. We only do this in the hospital for severe cases, okay? Most mild to moderate cases, give them a dose of dexamethasone, send them on their way. Really, really mild, even just that cool humidified air. So key takeaways here, okay? No antibiotics because it's viral. Watch out for those severe signs to escalate. If we need to escalate, it's racemic epi and dexamethasone. And the key finding, barking cough. That barking, they sound like a seal. That's on one of your tests. You guys, you know 100% you're dealing with croup. Now, I told you, there are 2 peds respiratory disorders where we have to worry about this stridor. Croup is one, and the other one is epiglottitis. Now, if there's one thing that you focus in on today, it should be epiglottitis because this is a life-threatening emergency. So it's likely to come up on your exams, on your boards, so that you can prove you're going to be a safe nurse. You're going to recognize this if you see it. Okay. Now, this is the first time I can tell you, epiglottitis, usually caused by a bacteria. Hib, Haemophilus influenzae type B, is the bacteria that usually causes epiglottitis. You might recognize that because it's a vaccine that we give in our neonatal vaccine schedule. We give it at 2, 4, and 6 months. That means that we don't see a lot of epiglottitis anymore. The nurses I work with who were nurses in the emergency department 40 years ago, they'd be like, there's epiglottitis every night. This was like a super common emergency. Now we have this vaccination. I have never seen a case of epiglottitis. I've worked in the peds ED for 10 years. I've yet to see epiglottitis in person. Okay. What happens is they get this bacteria. That infection triggers inflammation. Again, we got things getting bigger in the airway. And this time it's the epiglottis. That's that little flap that goes over your trachea when you swallow. That's great, right? Because then food goes down your esophagus instead of down your trachea and you don't aspirate every day. It's not so great if that little flap gets inflamed though, because it literally blocks off your trachea. Your whole airway is obstructed, which is why it's an emergency. It usually comes on very suddenly. They start tripoding, leaning forward, trying to breathe. They get this stridor and a muffled voice. They can't talk. They can't get words out because their airway's so occluded. We call this the hot potato voice, okay? They'll be so occluded that they're drooling because they literally can't swallow their own saliva. So drooling, dysphagia, dysphonia, tripoding. These are all signs we have a closing airway. And the key priority you need to know is that you better get someone in the room who knows how to intubate that child. I don't want you doing anything until there is someone in there who knows more than you do and has emergency airway equipment. You do not take a temperature, start an IV, start humidified oxygen. You do not do anything that could cause that child to cry, bear down, and then initiate laryngospasm that completely occludes their airway. Because then we lose our chance to intubate them and we have a whole like emergency thyroidectomy going on, or tracheostomy, excuse me. So that is no good. We're going to definitely avoid that. Priority in suspected epiglottitis, get someone in the room with that emergency airway equipment. Key symptoms, exam tips to focus in on here is make sure you know those signs of airway occlusion: the drooling, the dysphonia, the muffled hot potato voice, the stridor. You're really going to want to be able to pick up on those because they might be in a test question that then asks you, okay, what do you do? Yeah. So let's try that out. Let's see what you guys think of this practice question. We've got a kiddo, they've got epiglottitis, drooling, stridor, tripoding. What are you going to do first? Okay. Go ahead, read through these, put the letter of the correct answer down in the chat so I can see what you're thinking. Okay. Michelle, yeah, you got it. Latifa got it. Athena, Shirley, nice job. Sarah, totally. Leo's on it. Natasha, yes. Okay. You guys have heard my soapbox. I think everyone has got it. We are not looking at their throat. We are not starting an IV. We are preparing to intubate. We are going to get someone in the room with emergency airway equipment so that we don't cause laryngospasm and totally lose that airway. Now, this one was pretty straightforward. Let me just tell you, on some exams, you guys, they're going to try to trick you. They're going to give you vitals, and the kiddo is going to be like 50% on room air. It's like so dramatic. And one of the choices is going to be start humidified oxygen. And you're going to be like, okay, they are hypoxic. I've got to give them oxygen. And I totally agree they are hypoxic. We've got to give them oxygen. But still, if they are losing their airway, ABC, airway's the priority, preparing for intubation, getting that emergency airway equipment is still the priority. So do not let anyone trick you, okay, guys? All right, now before we move on to our chronic disorders, a little recap. Our acute, we started at the bottom. We did the bronchiolitis, the croup, the epiglottitis. Now we're going to move into the chronic. We're going to look at asthma and cystic fibrosis. But I just want to take a super fast second because I know we're online. A lot of you guys are tuning in on the go. If this is feeling overwhelming and you're feeling like I need a little bit of backup here, maybe you're in pediatrics right now in nursing school and you want more help, I'm just going to pop this up so you know where to go. You can go ahead and scan that. You can go to our site. These are all of our mentors, our amazing private tutors that will walk through any of this content with you guys one-on-one, completely individualized. Whether you want to talk to me about peds, whether you want to talk to Rebecca about critical care, to Samantha about nutrition. Brandon is our dosage calculation guru. If you've got a dose calc check off exam coming up and you need to test yourself, Brandon's your guy. We literally have somebody for everything. And I'm just stopping to show you this because I know as we go rapid fire, things start to get a little overwhelming. So absolutely scan that, tuck it away for later when you're like, oh, SOS, I need some backup, or just note down our email address up there and you can always reach out to tell us what we can help you with. NursingSchool@archerreview.com is where you're going to head, and we will make sure to have you covered. Okay. So any questions before we move on to our chronic disorders? We're going to talk about asthma. We're going to talk about cystic fibrosis. Okay, Harrison had a question on Facebook really quick. Do you have any tutorials for NCLEX prep? So if you're finishing up with nursing school and you're like, yep, let me get ready to go ahead and pass my NCLEX, we absolutely do. We've got combo packages. Our most purchased package is called the Sure Pass because we're sure you're going to pass. It's got a 99% pass rate. So just head over to archerreview.com and we're going to be able to show you all of those packages. We can comment with that link, Harrison, so that you actually get to look at it and see what might be the right fit for you. Okay. Any other questions before we talk about chronic disorders? Okay. Sounds like we're ready to go. Okay. Latifah's asking about readiness assessments for the NCLEX. We'll answer you over in that chat there so that you have all of that. Tasha asking about when we're going to have CCRN preparation, and that is coming in February. We're just a few weeks away from having complete CCRN prep for you, so stay tuned on that. All right. Hopefully I answered everybody. If there's anything outstanding, our friends in the chat will make sure to discuss with you so that you get the answer you need. And we'll just keep plugging along. We have 2 chronic disorders that I want to make sure you guys get a good understanding of. So the first, asthma. I know you guys have heard of asthma before. Probably the most common chronic condition in pediatrics. We see a whole lot of asthma. And honestly, I think a lot of people make it sound simple. Asthma is a complicated situation. It is chronic airway inflammation and hyper-responsiveness. And that second part is what I feel like people forget about. So not only does my airway get inflamed, which makes it smaller and harder to breathe, but my airway gets inflamed for no good reason, right? There's like a little speck of dust over here, or I'm anxious about a test, or I go run and play soccer. And instead of just, responding appropriately, my airway hyper responds. It goes into overdrive and poof, gets super, super inflamed. So that is right here. Hopefully you guys can kind of see where my cursor is. That bronchiole gets inflamed and constricted. So see, not very much air can go through there compared to a normal bronchiole there. And a big bummer is that as you have more and more of these episodes, the changes in your airway kind of add up over time, which means they're not reversible. And they continue to have symptoms like wheezing, chest tightness, where it's like they feel hard to breathe. They have this really like dry cough, especially at night. They'll be like up all night coughing. What is really, really important for these kiddos with asthma is to help them identify their triggers, okay? Lots of things can cause this hyper-responsive episode. Really common, it's something like allergens, dust mites, mold. It could also be sports, running and playing soccer, having a fever, getting an infection, or just being exposed to cold air. So I give them a little log and I'm like, okay, keep track of what you were doing around the time you have this episode. And then we can try to pick up on patterns. Because really for management, even before we get down into this pharmacology, I want them to avoid triggers. If we can avoid what causes you to have this flare up, all the better, because then we don't even have to use meds. But most of the time we have to use some meds. So the first one you got to know is albuterol. You guys know this. It is a beta agonist. So I saw some chat on Facebook about the beta receptors. We have 2 types, beta 1 in the heart, beta 2 in the lungs. I know you've all heard this because beta 1 in the heart, we have 1 heart, beta 2 in the lungs because we have 2 lungs. Now, when we have an agonist, they go attached to those receptors and they help them do what they're supposed to do. And beta receptors cause things to get bigger, to dilate. So in my lungs, that means that the airways, the bronchioles, are going to dilate when we activate those beta 2 receptors. So that's what albuterol does for us. It opens up our lungs. All right. It dilates, bronchiodilates. We get bigger airways. We can breathe easier. We're not wheezing, coughing, tight chest, right? So that's what we give in like an attack. Okay. It's like, oh my gosh, can't breathe while I'm running playing soccer. Here, take your quick relief albuterol. We use it PRN. And the more somebody uses it, the more severe we know their asthma is. If they've got to pop that albuterol inhaler like 2-3 times a day, we know we need to do something more long-term. Yeah. So that would be something like an inhaled corticosteroid. So that would be something that decreases inflammation over time. They take it every day, not just when they're having symptoms, right? They take it every single day to decrease that inflammation. And it should make them use their albuterol less, okay? They can also be given something called a leukotriene modifier. This is montelukast or Singulair, okay? What it does, it helps us out with that hyper responsiveness that we were talking about, okay? So we know the airway responds too quickly, it gets really inflamed. Well, the montelukast, those leukotriene modifiers, help modify our immune system so it doesn't react so crazy and we hopefully have less attacks. So you see why those are long-term interventions. Take them every day, hopefully prevent attacks. Take your albuterol when you're having an attack. Now, there's one more component to our long-term management here, which is kind of monitoring how well you're responding to treatment. We need to know if it's working or if we need to adjust your medications a little bit. And we use something called spirometry, which measures how much you can breathe in and out. And at home, a peak flow meter. So it kind of like looks like an inhaler like this. You breathe into it and we kind of measure, all right, how much can you breathe out when you're just at rest, you're feeling good, you're not having an attack. And then every morning we ask them to do the same. And when they're able to breathe out 80 to 100% of their personal best, they're in the green zone. They're looking good. It's a good day. They're hopefully not going to need their rescue inhaler, okay? Now, if they breathe out and it's only in the 60 to 80% range of their personal best, we're like, oh, you're having some airway restriction, okay? You're in the yellow zone. Make sure you take your long-term meds and, keep your albuterol on you. And if it's below that, they're in the red zone, they're having an attack, you need your albuterol. We got to open those airways up. So it's a quick way to assess how well are they breathing in and out? How tight are those airways? Okay. And that goes to one final point on asthma, a good exam tip too. You need to learn proper inhaler and spacer technique. Okay. These are common exam questions because if our clients are not using the meds correctly, they might as well not be using them at all, right? They're just not helping. So you got to shake that inhaler. Then you got to breathe all the air out. Seal your lips around the inhaler. And then you're going to press the medication and breathe in slow and deep so that you get all that medicine in there. That's a lot to coordinate, isn't it? I'm honestly not sure I could do that. I've never had to use an inhaler, but that just sounds like an awful lot. Especially for kids, this is going to be a big challenge and they might not get all that albuterol. So we use something called a spacer. It's like a little chamber. We attach that to the inhaler so that they can pump the medicine in. Just breathe like normal into the spacer so that they get all that medicine, okay? Now, last thing I'll say about the medicines here, watch out for side effects. Since we are activating beta receptors, remember we got beta receptors in the heart too? We activate those beta ones and it increases the heart rate. I've never seen anyone on albuterol who's not tachycardic. If you have tachycardia while using albuterol, it's normal. We're going to monitor it, okay? If it gets too much, then we need to think about doing something else. But you want to educate your client about that. Keep an eye on it. It can also make you a little bit jittery, okay? Because it's speeding things up. So that is asthma. Sum it up, wheezing, It's caused by a trigger. First line, albuterol, and then long-term, we use those inhaled corticosteroids and the leukotriene modifiers. If you're going to work with kids at all, you're definitely going to see asthma. So this is a good one to hone in on. All right. Now, we're going to do one practice question. Make sure you guys have got asthma. A nurse is teaching a parent about using that metered dose inhaler with a spacer, okay? Which statement indicates understanding of using that inhaler with the spacer, okay? Read through those. Think about which letter is the best answer and go ahead and put it down in your respective chats. Okay. Okay, Anna, yep, nice. Yeah. Good job, guys. Okay. Nice work, definitely. Okay, Shayna got it. Flavina, you're on it. You're on it. Shaking the inhaler before use. Absolutely correct. Because we want to really distribute that medication, mix it up before it is nebulized. We don't need to hold their breath. We don't need to rinse the spacer weekly. We need to rinse it after use. We definitely do not skip a dose, okay? Remember, long-term medications, those are going to be used every day. Doesn't matter if they feel fine. It's to prevent them from feeling not fine. So make sure they use it every day. All right. You guys have got asthma. So we'll shift gears and we'll talk about our very last one, our cystic fibrosis. Now, we have it here on respiratory. A lot of people think of cystic fibrosis as a respiratory problem because it does affect the lungs, but it's a genetic disorder and it has effects all throughout the body. So what happens here? It's autosomal recessive. They get this gene passed down, and this gene mutation causes their mucus to be thick and sticky. So it basically clogs things up, okay? It goes into the pancreas and clogs up those islets of Langerhans, preventing insulin from being released. All right, that can cause diabetes. It goes into the intestines, the stomach, the GI tract, gets really clogged up. Their stool is thick and sticky, causes constipation and a lot of bloating, okay? It can clog up any duct in the body. And since we're focused on respiratory, you know where we're going. It's clogging up those airways. That also means that we've got a bunch of mucus like hanging out, sitting there, making them really prone to infections. Lots of things like pseudomonas and streptococcus, they can just get on in there and grow and cause lots of infection, okay? So they're going to be coughing a lot. We're going to have lots of infections. They're not going to be absorbing their nutrients very well, so they're not going to grow like we would expect. Failure to thrive. When we start to see these symptoms, the first test we usually do, well, let me first back up and say this is on our newborn screening panels. So if we have an infant who maybe doesn't pass their meconium because it's thick and sticky, we send that newborn screening panel off, comes back, it can indicate cystic fibrosis. Then we need to do a confirmatory test, which is our sweat chloride test. This is actually very interesting in my opinion. They tend to have a really high level of chloride, of salt, in their sweat because of that mucus clogging up and causing some dysregulation in that integumentary system. So oftentimes, the first thing we hear that makes us think cystic fibrosis is the parent is like, they go to kiss their baby on the forehead, and they're like, this baby tastes salty. Like literally, I taste salt on my baby. And we're thinking, okay, we need to do a sweat chloride test. And that's going to actually measure how much chloride is in their sweat. And if it's above a certain level, that is diagnostic for cystic fibrosis. How do we manage it? We cannot cure cystic fibrosis. It is a genetic disorder. They inherited those genes. They have it forever. So they're going to have this thick, sticky mucus hanging out, and we need to help them get rid of it. Airway clearance is the name of the game. Bronchodilators, mucolytics to help break up that mucus, chest physiotherapy to help move it around, and then suction, suction, suction. We want to get that mucus out of there. That's going to help them breathe better and prevent more and more infections. Now, they are going to get some infections. They're very prone to it. We treat aggressively with IV antibiotics when they get an infection. We also have to think about the other components. Remember, this is multi-system. Their GI tract can't absorb very well, so they need vitamin supplements. They need a high-calorie diet to really get lots in there. Their pancreatic duct gets really clogged up with mucus, which means we can't release those pancreatic enzymes to break food down. So we have to give them exogenous, extra, external pancreatic enzymes that will actually break food down. With every single meal, they need pancreatic enzymes. When we think about an ABC priority, airway is first, clear that airway. Bronchodilators, mucolytics, break it all down, right? But then think about the whole person as well. Pancreatic enzymes to break their food down, help with absorption, and then we really got to give them a lot of calories so that they can grow. This failure to thrive right here, that is really the big thing that you're long-term addressing with cystic fibrosis. You're trying to give them the nutrition and support they need so they can grow. Okay, so let's do a little check-in. Last question here. Again, we're going to put our answers in the chat when you're ready. We've got a child with cystic fibrosis. They're being discharged. Which statement by the parents indicate the need for further teaching? Nice job, Michelle. Perfect. Tifa's got it. Amazing. Rebecca over there. Nice job. Good. Okay. Patrin Harrison. I love it. Shina's got it. Let's see over here. Yes, yes, yes. We are going to go with C. I will limit my child's fat intake to prevent digestion problems. Limiting is not the name of the game in cystic fibrosis. Remember, they can't break things down. They can't absorb them. So yeah, we need to give enzymes to help them break it down, but we don't want to limit how much they have. We are going to have high calorie, high nutritional needs. So we want to give them more, not limit. Yes, we're going to give them enzymes. Yes, we're going to do that chest PT, airway clearance. And I actually didn't touch on this, fluids. Fluids are a great way to thin out that mucus, help make it easier to clear with that suction. So that's what I've got for you guys. We went through all those acute disorders, starting low, bronchiolitis, croup, epiglottitis, and then our two most common chronic disorders. So with that being said, let's go ahead and just open it up. We're going to have an open Q&A. You guys talk to me about anything you want to. We've got a few more minutes on the calendar. So give me just a moment here to pull that up. You guys can go ahead and scan that QR code. Go ahead and go to slido.com if you want to. We've got a little key right there. And we will just go ahead and do this Q&A. Let's go full screen here. You guys go ahead and send any questions you want to, whether it is about pediatric respiratory, peds in general, how we can help you at Archer Review, whatever you are needing, you can go ahead and enter it, and we will see your questions right here. You can also pop them in the chat if you want to. We will make sure to continue answering all of your questions there too. Okay. When do you cover adult health topics? Nice question, Rebecca. And if we can have somebody in the chat go ahead and send Rebecca the schedule. We have webinars nearly every day. We have NCLEX webinars Monday, Wednesday, Friday, and nursing school webinars every Tuesday. So we have adult health content continuously. And we always post what's coming up on the social media as well. So those will tell you like the specific adult health topics so that you can go to the classes that are most beneficial for you. When do you do another pediatric chapter? Same answer. Follow on the socials at Archer Nursing. And we can also go ahead and send you that full calendar so you know what's coming up. Can I still join live lectures? Yep. We've got live lectures nearly every day. You can certainly join. We try to do on Zoom, Facebook, YouTube, Instagram, TikTok, so that you can just watch on the go wherever you are at. You can pop up and join. For the PEDS question, why wasn't racemic epi given? Okay. So when we're talking racemic epi, we are talking about Croup, and we've got that inflammation up in the upper airway. The first line intervention here is going to be dexamethasone, which is a steroid to decrease that inflammation. Only if that doesn't work do we need to do the racemic epi, right? Like that's kind of like our highest level of intervention. So we don't go there first. We only do it if we have to. And in that, it wasn't as severe. We didn't need to do it. Awesome. When do we do another pediatric chapter? I'm sure it'll be coming up very soon. Keep an eye on socials for that. I am preparing for my NCLEX. What's the best way to study with Archer Review? I love our SurePass program. I think that that is the way to go. If you're going to do something, do it right. And the SurePass program does it right. It includes all the components you need. So what you do is you watch one of my videos. I explain the things. You go and you take practice questions to check your knowledge. And you go through every single concept. Then you go to our 3-day live review where we go over the most important information, answer your questions in real time, really help you out. And then finally, you take your readiness assessments. Your readiness assessments are kind of like a mock NCLEX situation. They're going to test how ready you are and let you know if you really should go and take your exam or not. That way you can walk in with confidence. You're going to feel so good. So SurePass program, that is how I recommended preparing for your NCLEX. Let's see. Do we have a YouTube channel? Yes, we do. If we can maybe drop that in the comments or the chats, or if you just go to YouTube, you search Archer Review, you will definitely find our YouTube channel. We've got lots of free stuff on there, so for sure, utilize it. And we can definitely send you the link for the 3-day live as well. You can go to archerreview.com and we have all of our offerings readily available on there. If you already have an account and it's expired, you can definitely renew it. And we keep the price really, really low because we want you to have it as long as you need it. So just email our team at support@archerreview.com. They can set you up, or you can go ahead and just click on renew at the top of your student dashboard. That way you can pick how long you're going to need it for. Is the sweat test the only confirmatory test for cystic fibrosis? No, it is the gold standard. It's what's most common. It's totally what you're going to see on your exams. But we do have genetic testing as well, where we can look at the genome. We can see certain mutations. That's kind of specialty level. It's not something I know a ton about. I've never worked in genetics, but I do know we've got those genetic tests too. I'm studying for my NCLEX. My average score is 57 and the peer score is 64. How do I interpret that? What do I know? This is a great question. We're used to a nursing school needing like an 80% or a 90% to pass. And that's not how the NCLEX works. The NCLEX compares how you're doing to how your peers are doing and then says, okay, you're either on track, above, or below. And if you're below, you're not a safe nurse, and that's when you have a fail. So we do the exact same thing at Archer Review. We try to make it as similar as possible to the NCLEX. You're going to see the peer score, your score, and then you're going to see to the right of that 4 different categories. You will either be low, borderline, high, or very high. And those are categories based on how close you were to that peer score. So instead of looking at the numbers, I just need you to go look at that little slider and see where it is. If 57 is just a bit below the peer average, you'll be borderline. If it's a lot below, it might be low. And with neither of those, are you ready? You have got to be at or above that peer average, okay? And that results in a high or very high readiness level, which tells us, yes, you are ready to go. Interpreting the CPR report is a little bit similar to that. So for those who don't know, that's the candidate performance report that you get if you are unsuccessful on the NCLEX. And it shows you every area of the NCLEX test plan. And then it tells you, hey, you were either below, near, or above the passing standard. The passing standard is that peer score, okay? We just call it something different. Peer score, passing standard. That's where you need to be. And on the NCLEX, you have to be above the passing standard in every single one of the categories. If you're below on anything, it's considered unsafe and you will not pass the exam. So when I look at a CPR, I say, okay, go ahead and circle the areas that you are below the passing standard. And those are the ones you need to focus in on. Go to those videos, go to those practice questions on Archer Review, and practice, practice, practice until you get those high or very high scores. All right. I've taken 6 exams, 5 very high and 1 borderline. You are ready. If you have taken 4 readiness exams with a score of high or very high in a row, then you are good to go. Can I still join the 3-day live tomorrow? And will the booklet be ready? I need the link for it. Yes, yes, and yes. We can get you the link. We can get you the booklet. We can get you signed up. If you want to email us, I think we've got the email over here in the chat somewhere. We'll make sure to put it in both the Zoom chat and the social media chats as well. But you can email us at nclextutors@archerreview.com. If you are missing the link, if you need the booklet, if you need help with signing up, we will happily get you into that. We can definitely accommodate you in the 3-day live tomorrow, and we can get you that book. Okay. Where do I find the readiness assessment in the SurePass program? You are going to go to your question bank, click on Create Test, and then there's a little box that says Readiness Assessment. You're going to check that, and you will be off to the races to take that readiness assessment. So everyone, good luck. I wish we had a little bit more time, but we are going to start to wrap it up for the day. Remember that we do this every single week as far as the nursing school webinars. We also have NCLEX webinars every Monday, Wednesday, and Friday. So if you're not already following us at Archer Nursing, that's where you're going to see announcements for all the webinars. You can also find them on our website, archerreview.com. That is where you're going to be able to sign up for all of these things, whether it's a tutoring session, our nursing school product, or anything in between. We are so thankful you are here and part of the Archer family. If you can't tell, we all really love being here. I'm just a nurse that loves being a nurse, and I want you to love it too. So if there's anything we can do to help get you there, don't hesitate to shoot us an email, and we can't wait to see you again next time. Bye, everyone.